My name is Michael Grunwald. I am a leukemia specialist at the Levine Cancer Institute in Charlotte, North Carolina, and I'm presenting a case study in polycythemia vera. Our patient is a 48-year-old female diagnosed with PV approximately 12 years ago. She initially presented with erythrocytosis, thrombocytosis, and leukocytosis, and was later found to be positive for the JAK2 V617F mutation. She was treated intermittently with phlebotomy, hydroxyurea, and an agrolide. She received aspirin as well. She presented to the emergency room 3 years ago with abdominal distension and pain. At that point in time, she had erythrocytosis with a hematocrit of 61%, thrombocytosis with a platelet count of 584,000, and leukocytosis with a white blood cell count of 43,000. Her liver function tests were also elevated. Her AST was 186, ALT 216, alkaline phosphatase 250, and total bilirubin 4.6. She underwent imaging which revealed the presence of Budd-Chiari syndrome. The patient ultimately underwent orthotopic liver transplantation. Following transplantation, her white blood cell count was 22,000, her hematocrit was 54%, and her platelet count was 415,000. She was treated with phlebotomy and hydroxyurea. The patient was on hydroxyurea doses that ranged from a total of 500 milligrams daily to 1,500 milligrams daily in divided doses. And every time that she achieved control of her hematocrit with hydroxyurea, her blood counts would start to plummet. Her hematocrit would become too low, even on low doses of hydroxyurea. Her white blood cell count would get low, and her platelet count would become low as well. She would have her hydroxyurea held for periods of time, and it would restart on 500 milligrams daily of hydroxyurea, and her blood counts would rise rapidly, prompting increases in the hydroxyurea dose, which then in turn prompted the counts to decrease, which resulted in anemia, leukopenia, and thrombocytopenia again. The European Leukemia Net Consensus Project divides patients with hydroxyurea resistance and/or intolerance into 5 categories. There are patients who exhibit a need for a phlebotomy, patients with uncontrolled myeloproliferation, those with refractory splenomegaly, patients with cytopenias, and patients with non-hematologic toxicity. To add a little bit more color to those categories, the first category consists of patients who exhibit a need for phlebotomy to maintain their hematocrit under 45% after 3 months of at least 2 grams per day of hydroxyurea. The second category of uncontrolled myeloproliferation consists of patients who exhibit a platelet count greater than 400,000 and white count greater than 10,000 after 3 months of at least 2 grams per day of hydroxyurea. The third category consists of patients who exhibit a failure to reduce massive splenomegaly by more than 50% or failure to relieve splenomegaly symptoms after 3 months of at least 2 grams per day of hydroxyurea. The fourth category consists of patients who have an ANC or absolute neutrophil count less than 1,000 or a platelet count less than 100,000 or a hemoglobin less than 10 grams per deciliter at the lowest dose of hydroxyurea required to achieve a complete or partial response. And the final category consists of patients who exhibit unacceptable hydroxyurea-related non-hematologic toxicities, which include leg ulcers and other toxicities. Our patient met criteria for hydroxyurea resistance. She exhibited an absolute neutrophil count less than 1,000, a platelet count less than 100,000, and a hemoglobin less than 10 grams per deciliter at the lowest dose of hydroxyurea required to achieve a complete or partial response. Please note that she happened to meet all 3 of those criteria, but she only needed to meet one of those cytopenias in order to qualify as a hydroxyurea-resistant patient. For 4 months, the patient was subsequently treated with pegylated interferon at doses ranging from 45 micrograms to 90 micrograms subcutaneously weekly. Counts were well controlled on pegylated interferon. However, the patient exhibited elevated liver function tests, severe fatigue, edema, and a rash while on pegylated interferon, requiring discontinuation of this agent. The patient was then initiated on Ruxolitinib 10 milligrams by mouth twice daily. On Ruxolitinib, the patient's blood counts have been relatively stable for many months. The patient's hematocrit is stable in the 35% range without any additional phlebotomy or hydroxyurea. The patient's white blood cell count has been slightly low but stable, and she's maintained an absolute neutrophil count greater than 1,000. And her platelet count has been within the normal range as well. To summarize, this case illustrates one type of hydroxyurea failure, namely the occurrence of significant cytopenias in the context of hydroxyurea treatment. The patient also happened to have intolerance of pegylated interferon. Ruxolitinib is a treatment option for polycythemia vera patients who have an inadequate response to or cannot tolerate hydroxyurea. Thank you very much for your attention.